I'm very pleased today to have Dame Margaret Sparrow with me to talk about fertility control and women's access to fertility, particularly in New Zealand. But Margaret has been a pioneer worldwide in this field, and I'm really delighted to have you here today, Margaret, and I'm looking forward to hearing your views on a variety of issues. I'd love to know a little bit about what led you into this field, and then we'll have a chat about other issues. Welcome.
Thank you very much. I've been a great admirer of the work that you've done for women's global health. I think mine is small in comparison. How did I get involved in this issue? I think it came after I'd finished my medical training and I was seeing patients and realising that people needed help back in the 1960s with contraception in New Zealand. Although the pill had already arrived, it was unethical, according to the Medical Association, for doctors to prescribe the pill to anybody other than married women. It didn't matter what age you were, you had to be married. I was fortunate in that in 1961, I just had my second child. I was young and I was healthy, and so I was able to use the contraceptive pill, although I didn't actually go to a doctor because my husband was a medical student and he obtained some free supplies, and I lived on free supplies for as long as I needed to. In those days, of course, the pill was quite high in dose. Many women had side effects, but I was very fortunate and didn't. So it was quite a lesson for me, and I became very interested in family planning when I had my first job in general practice at the university in Wellington. I had lots of students. I realised that they needed contraceptive help, although according to the Medical Association to which I belonged, they were not really eligible. So that was my first foray into improving what I thought was the correct service that women should have.
And in your medical practice, did you actually focus on obstetrics, family planning? Was that your focus?
It became my focus, yes. I started as a general practitioner for the, I started, my first job after graduation was in public health. So I did lots of speaking and talking and became interested in public health issues. And that included sexually transmitted diseases in those days. So it was part of my background in public health. But when I had my first job in general practice at the university, then I realised soon that contraception was a part of that practice, and I became very interested because I hadn't had much training in my medical studies. We had only one lecture on contraception in the whole of my medical degree. I teamed up with the local family planning clinic, and I've been with them ever since, and they taught me a lot of what I knew, and I'm still a member of the Family Planning Association. But the students also needed help with in preventing unplanned pregnancies in other ways, and I was one of the first practitioners in New Zealand to offer the emergency contraception. That was quite new at that time, and I became involved in that. And
what was the situation in New Zealand for women in terms of controlling their fertility in the 1960s, and then bring us up to date to what's the situation now in terms of a person's desire to contracept or possibly to terminate a pregnancy if it was not the right timing? What was the situation back in the 1960s and through these years until now?
In the 1960s, the pill arrived fairly early in New Zealand in 1961, prior to that, it was rather difficult to find good contraception. The Family Planning Association had nurses and a very few doctors trained in the fitting of diaphragms. Condoms were not popular in New Zealand. We didn't have a rubber industry. They had to come from overseas, and they perish on the way through the tropics and were not highly regarded as they were in some other countries. So there were very few methods of contraception that were readily available, and especially to young people. Mm-hmm. The Medical Association only approved of the use of the contraceptive pill for married women. And for many years, arising from a huge public debate that we had here in 1954, it was actually illegal to talk about contraception, certainly not to prescribe contraception for under 16 years of age. We had quite a moral panic in the 50s when young people were accused of sexual misdemeanors, and a law was passed prohibiting. I don't know how restricting contraception would help that, but the lawmakers of the time thought that it would, and so we had this curious legislation on our book restricting even the education of young people. So it was very difficult for young people, and not easy for married people either, and not a great role for men either, because condoms were not a favoured method in New Zealand. They were thought to be rather unreliable, and withdrawal would be commonly practiced, and vasectomy was not then popular, and that's one of the things that I did in family planning, was to introduce a vasectomy service in Wellington.
And what changed, and when did that change over time in New Zealand? That was a long time ago.
I think the biggest change came with the feminist movement in the 70s, in the early 70s, and women began to see that they did have rights to fertility control, and that fertility control was important if they were to achieve other aims in life, rather than just being mothers and having one child after another.
Mm-hmm. You refer to fertility control as a right, and that would raise the issue not only of access to contraception, but also access to the means to terminate a pregnancy. Why is this your focus? What importance do we give to this particular, you might say, human right to control one's fertility?
I think unless a woman has control over her fertility, then she's not able to take advantage of all the other rights to participate in society other than childbearing and child rearing. Mm-hmm. And I think that many women do have aspirations beyond, although child rearing and parenting is so important, many women have aspirations beyond that and want to participate in the life of their community, and can best do so if their health is improved through not having frequent childbearing, and also the economic costs that raising children is expensive, and the need to control your fertility is therefore fundamental.
Mm-hmm. Coming to today in New Zealand and recognizing that even modern forms of contraception can fail, can you update us on the issue of access to contraception and access to pregnancy termination in this country now?
In New Zealand now, most people have good access to contraception. Sex education is part of the school curriculum. We have removed the restrictive legislation that for many years prevented us providing contraception to under 16-year-olds. And access to modern methods is readily available. The pill has always been highly used by New Zealand women. LARCs, or long-acting contraceptive methods, are becoming more popular and have helped to reduce the abortion rate in New Zealand. And one of the other big advances is that nurses are now able to insert long-acting contraceptive devices. And I think the use of nurses and chemists in the provision of emergency contraception, and nurses in the provision of all methods, including implants, has made contraception more accessible. Perhaps not so for rural women. Many women do have to travel, and in New Zealand that makes it a little bit difficult for some women. There are regional differences, and same with abortion services. They are not evenly distributed throughout New Zealand, so some women do find access to abortion services difficult. Very little problems with sterilisation, and New Zealand men have been quite good in, I shouldn't say good, but have taken up vasectomy. Many men will say, I've seen my wife having to take pills, perhaps have side effects, bear the responsibility for most contraception, and this is something that I can do. And I think that New Zealand men, although they have a reputation for rugby and beer, they are also good family men, and so vasectomy is quite popular in New Zealand as well, and usually no difficulty in obtaining female sterilisation either. So contraception is pretty widely available, and one would ask why in a country which is regarded as well developed and there is good access to contraception, why do we still have a high proportion of unplanned pregnancies, which we do? And I think the answer to that is quite complex, but it certainly goes back to our history and the stigma that has been attached to both contraception, not so much now, and abortion, which is still quite prevalent. For instance, abortion in New Zealand is still regarded as a crime rather than as a health issue. And so I think that these things take time. Although sex education is part of the curriculum, it's very patchy. And I think that we don't appreciate always how difficult it is for people to make decisions about fertility control in a romantic situation, and certainly not in a rape situation or in a forced situation. So I think that we'll always need to have a backup of abortion services, no matter how good contraception is, no matter how well educated the population is. We are human, we make mistakes, we will still have unplanned pregnancies, and although we try to keep them to the minimum, I'm very adamant that abortion services must always be present, and that women should have access to these without difficulty. So contraception good, abortion not quite so good, because we still have quite a bit of restrictive measures in our legislation. In the early days of New Zealand in the 19th century, we inherited the British laws of 1861, and they were on our books for many, many years. In Britain, the law was changed in 1967, and many Commonwealth countries would have taken that as a lead and changed their own laws regarding abortion, but we chose not to. And it was not until 10 years later, in 1977, that we changed our laws. And that was partly due to the feminist movement. There had been quite a concerted action by women's groups to have the role of women in society redefined. And so that was important. Bringing us up to the present day, abortion services are complicated. A woman does not have the right in law to make her own decision. The decision has to be made by two doctors called certifying consultants. So in 1977, instead of going the way that Britain did, we set up our own peculiar laws with all these restrictions, mainly because politicians just didn't trust women to make a decision, whereas I believe women can be trusted. But our present law that we've had since 1977 did make a lot of improvements. For instance, it removed backstreet abortions. When I grew up in the 50s, there was no medical access to abortion at all. When I was a young woman in the 50s and I found myself in the situation of having an unplanned pregnancy, I did it myself. Mm-hmm. In my case, chemists of the day widely advertised abortifacients, and I knew that if you wrote away to George Bettle, the chemist in Christchurch, that you could get a potion that was sent to you, and it wasn't an exorbitant price. And I can remember taking this black mixture, goodness knows what it contained, 1 tablespoonful 3 times a day, and it did produce, in my case, because it was an early pregnancy, I presume, produced a miscarriage, and many women just relied on do-it-yourself methods. If those didn't work, and they often didn't work, then there was always in New Zealand the backstreet abortionist, and that was so until 1977. So if women didn't do it themselves, or they went to a practitioner, sometimes a medical person, sometimes anybody who was often just trading on vulnerable women, and that was the situation in 1977. Although, but this raises another point, that abortion services have always been there for women with money, and it's the poor women who have always been denied abortion services or been forced to continue a pregnancy against their will.
In New Zealand now, is emergency contraception available, the pill to abort an early pregnancy? And maybe you describe the method.
Yes, the emergency contraceptive pill has been available. Back in the late 1960s and very early 70s, I was involved in introducing the emergency contraception method to New Zealand. And in my time, one of the pleasures has been to see the improvements in emergency contraception, the types of emergency contraception that is now available, and also the means of accessing it. It's now available through pharmacies, so a woman doesn't need to go to a doctor. It can be obtained from a pharmacist, and pharmacists have been trained to provide this service. So,
what is the method?
The method now is a single dose of progestogen only. Our early methods of emergency contraception, the very first method that I used was high doses of estrogen, which did have a lot of side effects. And then we moved to the USP method, which was a combination of estrogen and progestogen. And then we've since then moved to progestogen only, which is more effective, less side effects, and now available from pharmacies.
Mm-hmm. Okay, what else would you like to talk about? You have an audience of students around the world interested in international women's health and human rights, and I wonder if you'd like to comment in any way on any topic that you'd like to reach out to this group.
I think that abortion is universal. There are no communities where it isn't practiced, isn't needed, and I think that we need to recognise this, that even if we're very diligent in providing contraception, contraception is not 100% perfect. People still get raped, people still find themselves under the influence of drugs, and alcohol is a problem. And therefore we will always need good abortion services, and these should be as early as possible, because the earlier an abortion is done, the safer it is. And it should be the right of the woman to decide, because only she knows the situation in her life. Only she has to live with the consequences. And my experience is that when a woman does have an unplanned pregnancy, there's a very strong need in women to terminate that pregnancy in many situations, and therefore she will do risky things if safe things are not available. And worldwide, of course, the biggest problem is that in many countries, not only are there laws which restrict abortion, but medical services are just not there to provide a safe service. And another thing that I have noted is that the practice of abortion is often quite different to the laws on the books. And that, for instance, is so in New Zealand. If you read the law in New Zealand, you would think that it was quite restrictive. There are barriers and hurdles. Women can't make the decision. 2 doctors must do this, etc., etc. But in practice, because the law is interpreted liberally by the medical profession, abortion access is actually readily available. And the curious thing in New Zealand, and this has happened in other parts of the world, is that when there is a mental health ground, in our case, 98% of abortions are done on the grounds of mental health, which to me is ridiculous. So one of the things that I think is important to mention is that laws are important, yes, but medical services are actually equally important. The other thing that I would say is that over the last decade particularly, I think that abortion has been recognised more internationally, and one doesn't feel so alone in coping with abortion. And I have found a lot of support from the international community. Yes, every country has their own specific contraception and abortion situation, but we all learn from each other's, and I have learnt so much from other countries. The other thing that I would say that I have noted is that more and more we are treating abortion as one of the very important components of reproductive rights, and that there has been a huge increase in the recognition of human rights generally, reproductive rights in particular, and abortion being a component of human rights. Mm-hmm. And I think the lead that has been taken by the United Nations, for instance, has been, to me, one of the real advances in the last decade or so.
Thanks so much for taking time today, Margaret. Thank you.
My pleasure.